Hi, and thank you for joining us for today's Mayo Clinic Facebook Live broadcast. My name is Brianne Prothro, and today we are talking about pediatric inflammatory bowel disease, me, my child, and IBD, how to manage. We realize that much of care related to IBD has to do with items that are out of your control, like appointments, medications, and flares. So today we would like to empower families and patients with a discussion related to priorities over which you have full control, issues like diet, physical activity, psychosocial needs, and more. We will be taking your questions throughout the broadcast, so make sure to post your questions in the comment section below. Joining us today's discussion is Dr. Bill Faubion and Megan Wagner. Dr. Faubion is the medical director of the Pediatric Inflammatory Bowel Disease Clinic at Mayo Clinic Children's Center. He is also the director of the Pediatric IBD Clinical Trials. He's a professor of immunology and pediatrics at Mayo Clinic School of Medicine. Megan Wagner is a registered nurse with a pediatric certification. Dr. Faubion and Megan, thank you so much for joining us. Let's start today's conversation off by talking about the importance of diet and nutrition in the management of pediatric IBD. Dr. Faubion, Megan, how important is diet and nutrition in the management of pediatric IBD?
Bree, thanks very much. So we would like this obviously to be as interactive as possible, so we'll be taking questions throughout the afternoon on this. I think as I thought about this question, I think that we need to first discuss the fact that when we talk about diet to treat active disease, and we also talk about diet to maintain a healthy lifestyle. So I think it's important probably for the viewers to understand and to know that there definitely are trials demonstrating efficacy of certain diets in flares of disease. Much of that data is older data, a lot of it from Europe and from Canada. But in those original papers, it was well established that taking a diet that was either by vein or even perhaps more importantly, a pre-digested diet by either a tube or even drinking it, indeed does place patients in remission that are flaring. That data probably is stronger for ulcerative colitis, but that data definitely exists. So I think probably the first place to start with diet is there definitely are established diets to control flares. I think the bigger question is, what do folks do when they're now in remission? We can discuss that a little bit more, but I think probably also, maybe I'll ask Megan, what are sort of the common things? So we see patients together, and many times I'll have a discussion with the family and I'll step out of the room. You come back in and field a lot of questions about diet. What are kind of the top questions that you get about managing diet with this disease?
Yeah, I'd say that's probably the number one question I get when you walk out of the room is, what can I eat? What can I do to help me feel better? What can we do at home? Some practical things. So a lot of times I explain to patients that it's really not one size fits all for everybody. There's no one diet that's going to make, work for everybody across the board. There are some things though that we have you do, especially if you're in an active flare, to help you feel better. So a lot of times we'll say low fiber diet. So it's the one time you get to tell your kid they don't have to eat broccoli. So they enjoy that. No salad, no broccoli. We also say, avoid nuts, seeds, some of those types of things, popcorn, if you have a lot of that active inflammation in your gut. And then just simple sugars, avoiding the high fructose, the sugary drinks, juices, things like that. If you have a lot of diarrhea, that can just help with some of that diarrhea. So those are some practical things that we tell people to do. I also strongly encourage people to keep a food diary because, like I said, it's not one size fits all for everybody. So they might notice patterns that emerge, food triggers that help make their symptoms worse if they keep track of what they're eating. So a food diary can help with that. Some of the common offenders people find it could be dairy. Some people have a lot of trouble with that, but again, it's not going to be the same thing for every person.
Right. Great.
Yeah.
Moving beyond, you're right. I mean, fructose, we see a lot of that in our non-IBD population causing diarrhea, right? So, just eliminating fructose from the diet, many times people have symptom relief regardless of whether or not they even have underlying IBD. One thing I would comment on as it relates to diet, one thing I really try to preface our patients with and their families is that what we eat probably most importantly regulates not only the types of bugs that live in our intestine, but what those bugs are doing, their metabolic profile or metabolic rate. So when folks ask me this question, what's the right diet for my child with inflammatory bowel disease, I usually preface it with, I'm an absolute and complete believer that what we eat regulates the bugs in our intestine.
Right.
And not only the who's who, the colonies that are there, but again, more importantly, what they do. A lot of interesting data emerging, both within the field of inflammatory bowel disease and outside the field of inflammatory bowel disease, about how a Western diet versus a non-Western diet versus a Mediterranean diet really deeply regulates the population of bugs that live in our intestine. Now, we don't know what the right mix of microbiome are now in order to either, cause remission or maintain remission. We don't know those yet. There's a lot of active research going in this, but I'm a true believer in that.
Yeah.
I think that I would also add that in the absence, perhaps, of a lot of fact yet, there are a lot of interesting trials ongoing with certain types of diets, and many people in our audience may be familiar with some of these diets that they could find on the internet or even on clinicaltrials.gov website of certain trials that are running. A question, I suppose, that that we sort of anticipated was the SCD diet, or the specific carbohydrate free diet. I think there's been a lot of active interest on the research space for this diet. And I think I can summarize a body of literature saying that larger studies are needed. Dietary trials are difficult for a variety of reasons. I think one of the reasons dietary trials are difficult is because it's very difficult to go home with that family and figure out really what they are eating, which is why your food diary, I think, is such a good idea. So they're difficult in that space, and then they're also difficult because getting a true validated outcome measure may take a period of time, and it's hard for people to stay on a diet for any particular period of time. I think the data that's emerged so far shows some interest in symptom response, but I think objective evidence, either by endoscopy or imaging, that shows sustained intestinal mucosal response, something one can see through a scope. That, as of yet, is lacking, and I think that we're excited about ongoing studies.
Yeah. I think, we usually encourage patients, when I'm educating them, is just if you're motivated and you want to pursue this diet, we're not going to discourage you, especially if it makes you feel better. The challenges I've seen come up with kids are, is just wanting to eat like their peers. So that's some of the hard things to tackle with a very specific diet is, mom might be preparing an SCD diet at home, but when the teenager goes out, they might not be following it. So those are some of those barriers that we kind of, encourage people to just kind of go into things with that open mind, and, that their diets aren't easy to follow, like you mentioned, but we certainly will provide all the support we can to help you pursue that diet. If you want to do it, there's nothing that says you can't. Yeah.
So no specific diets related to Crohn's and ulcerative colitis yet that we know of. But what about supplements? Do we see any information on aloe juice, probiotics, anything like that to help with either of the diseases?
Sure, yeah.
I'll try to field that one first.
Yeah, go for it.
So the one caveat I would say about Crohn's versus UC, you're absolutely right. There's no specific Crohn's diet or specific UC diet. Now, what I always tell families is if they have a narrowing, right, then there's a plumbing issue. So if one does have Crohn's disease in a tight spot in the small bowel, we may ask you to be on a low roughage diet, because things like broccoli and mushrooms and corn are well known to impact either inflammatory or fibrotic narrowings or strictures. And so if that's the case, people can get obstruction. It may not be driving the disease, but it's more of a plumbing issue. So good question about the supplements. You mentioned aloe, and it's interesting that you mentioned it. So probably of all the supplements that exist out there, if you do a hard look with published literature, you can find some clinical trials that have been run with aloe. Most of those studies were run in Germany. And did show some efficacy, but again, we have to remember when we're talking about interpretation of clinical trials, sometimes trials have a subjective outcome. You feel better, less cramping, etc. But when you actually start to look under the covers and decide, whether or not this looks like something that's going to make it in prime time, you have to have more validated outcome measures, things that encompass endoscopy, maybe certain biomarkers, imaging. And so, again, larger studies are needed, but you will find some clinical data available. As Megan mentioned prior, I don't know of anything that aloe is dangerous for. So if somebody wants to utilize that as a supplement, there is some evidence that exists in the world literature about that. And as long as it's not in lieu of something that's important for their bioenergetic needs, then I would have no problem with it.
Right.
And regarding supplements are concerned, or probiotics or prebiotics, there's an awful lot out there. You can walk into almost any convenience store or drugstore and find an entire shelf full of therapies for intestinal health. I think that my overarching comment would be buyer beware, that there's very little, if any, clinical data to support the utilization of commercially available probiotics and prebiotics right now. Caveats to that would be, and the audience may be aware, caveats to that would be some studies that were done with a certain concoction of bugs. The VSL number 3 is a product that was found to be useful in Italy anyway, in people with chronic inflammation of the so-called pouchitis. So folks with ulcerative colitis that have had their colon removed and they've had an operation where their small bowel is the new rectum, if you will. Many of those patients develop inflammation. We call that pouchitis. And so VSL number 3 was shown to be effective in an Italian study. There have been subsequent studies with that product and others for many times ulcerative colitis, primarily ulcerative colitis, with very mixed results, probably results that wouldn't yet change practice. But again, a lot of interest. I think probably and then I'll
no, you're good.
and then probably I would leave that with the future of that type of science is going to be driven by microbiome research. So as we understand more and more about what the bugs that are present in inflammatory bowel disease, and even more importantly, what they're doing, I think you'll start seeing more products that are very specific, trying to work with a certain section or faction of bugs, if you will.
Yeah. I think the take-home messages when I talk to patients is, again, we're not going to discourage you from doing it if it's something you want to actively pursue, but we don't want it to replace your medical therapy or whatever the medical recommendations are. And then just, a caveat we mentioned is that those probiotics can be very expensive, so we don't want it to put a financial burden on you, so just to keep that in the back of your mind when you're pursuing those types of therapies. Yeah.
Good advice.
Mm-hmm. So diet and nutrition, obviously important, and as Megan said, medication is kind of the big thing to take home. Dr. Faubion, can you give us an overview on medications that the child might be on for IBD management?
Absolutely. So we'll start probably, let's do this by era, I think, and ending with some of the more advanced therapies that are available now. So many years ago, probably before either one of you were practicing, all we really had in our armamentarium to treat inflammatory bowel disease were steroids, corticosteroids, and derivatives of sulfasalazine, the so-called 5-ASA products. So back in the 80s, if you saw an inflammatory bowel disease patient, really your best therapy was a steroid-related product or a 5-ASA product. Those still are effective. We try to stay away with steroid use now for a lot of the now well-described caveats to steroid therapy and its deleterious effect on height, particularly to the pediatric population, growth. And as many registries have shown, steroids are really one of the very few medications with inflammatory bowel disease that are associated with death. So we really do try to limit our steroid use. 5-ASA products are still widely used, primarily with colonic inflammation, be it Crohn's colitis or ulcerative colitis. And it's a mainstay to, I think, many practices that see a lot of new onset or community type IBD patients. Here at a tertiary care referral center, we probably don't have as many patients that can get by on a 5-ASA product, but they're certainly tried and true, very effective medications. Moving into the sort of late 70s and 80s, we had the thiopurines, both 6-MP and azathioprine. And those medications really we utilized a lot is what we described as steroid sparing agents. So patients that couldn't get off their corticosteroids may go on a product like that. I think that the utility of those medications has morphed over time with the advent of the so-called biologic therapies. I think that that we call a biologic therapy a biologic because it's not produced synthetically in a laboratory, but it utilizes a biological vector, so a cell or an animal, in order to be produced. That's why we call them a biologic. Most of those medications are what we call antibodies, and so as of this date, they're primarily prescribed by giving them IV or with subcutaneous shot. The first on the market was infliximab, went through its testing and approval in the mid and late 90s, and now we all know is one of the few medications for inflammatory bowel disease actually approved for children. Yep. And as I said, the utilization of some of these earlier products have morphed. Many physicians now use that secondary agent, that older agent, to allow those biologic agents to have a more durable response, to decrease the risk of people responding or reacting against the medication. There are now many other medications like infliximab. Infliximab, which was designed against a certain protein called TNF, that class of medications are called anti-TNFs. These products in general treat cytokine pathways, and as both of you have heard when I talk to patients about cytokines, I like to refer to them as text messages for the immune system. So when an immune cell comes to an inflamed segment of bowel, it sends out these text messages recruiting more and more of its kind to that environment. TNF isn't the only cytokine that's produced in intestinal inflammation. There are many other pathways that seem to be important. So because of that, there's now an emergence of other types of anti-cytokine medications. Many of those medications are going through clinical trials right now for children, but have FDA approval for adults. So some of our families may well have had the opportunity to go on a medication, so-called off-label use, before they come to us. And then beyond anti-cytokine therapies, I think that there's emerging therapies on regulating how a cell moves, so how it goes from the bloodstream trafficking to the intestine, so the so-called anti-trafficking agents. And vedolizumab would be probably the first on the block there for inflammatory bowel disease. I think the future is bright for therapies for inflammatory bowel disease. I think that a couple of commonalities that we'll see moving into the decades of the future would be we're going to be moving towards more oral therapies, so medications that one can take by mouth rather than having to take it by vein or by shot. And then probably also more personalized therapies. So as we understand more and more what the unique drivers are for inflammation in every particular patient, I think that we're going to be able to prescribe in a much more efficient, effective, and safe manner than we do now, the so-called personalization of therapies.
So Megan, question for you. What are side effects that you often see patients complain of, and how would you recommend managing those?
Sure. I'd say starting with each classification, the 5 ASAs that he mentioned, those are usually an oral medication. Those are usually tolerated really well. Kids do well on that. I'd say the biggest hurdle with those medications is when you have a pediatric person, they can be difficult to take. So it's usually a lot of pills to take in one day. Or if it's not a lot of pills, maybe it's a big pill. So those are things that we would talk to you about, strategies for taking the medication to make sure you're getting the right medication for your disease the right way. So that can be a difficult challenge with those. But otherwise, big picture, they're tolerated really well, not a lot of side effects that they see. Then moving on to the other the thiopurines he talked about. Sometimes we'll have kids who maybe might have some issues with nausea. Maybe we have concerns, we monitor their lab work closely because maybe we have some, things that we want to watch with that. So those, I'd say the nausea piece, it's different for every person, so one patient may not tolerate that thiopurine medication well, and one patient may do great. And so we kind of individualize that care for each patient. Whether they need to be on an anti-nausea medication or not, whether we need to strategize how you're going to take that medication, whether it's a certain time of day, a certain time of the week. Those are things we kind of individualize your care to, if that medication is working for you, to keep it working for you for your IBD. And then, people tend to have a lot of questions about that biologic classification that you were talking about, and how is this going to affect me? Because you mentioned, some of them are given IV, and that's kind of a big life changer. If you're getting an IV medication, maybe you have to go into an infusion center to get that. Remicade is usually tolerated well in the sense that it doesn't cause a lot of nausea, vomiting, make you feel bad when you're getting it. But kids can have infusion reactions, and so that's why we're going to give it to you in an infusion center with a nurse watching you, monitoring how you're doing. And most people tend to tolerate it really well, but there are those instances where we just want to make sure you're safe when you're getting that medication. But, I always tell people, it's not a medication where the rest of the day maybe you're going to be laying in bed feeling crummy. Once you're done with your therapy, your IV comes out, you go home, you can go back to school, things like that. And, alternately, the other anti-TNF that we haven't really mentioned yet, Humira, that's a self-injection, and that tends to be go really well. People give that to themselves at home. You don't need to be monitored by a nurse, things like that. Not a lot of major side effects. The only one we mention with that is just kids can get an injection site reaction, maybe some irritation or redness at that injection site. So if that happens with any of the medications, not just Humira, but any of the other medications, then we might, have you take an antihistamine prior to doing your injection. But those are kind of the broad things that we talk about with each different classification of medications. But big picture, most kids do really well on these medications, and we kind of individualize their care plan depending on what they're on and what they need. Yeah.
Now, do these medications cause cancer?
Good question. So that's obviously the big fear, right? I think that there are some definitive answers, and then there's some less definitive concerns. The first question is definitive answers. The thiopurines, the older medications, azathioprine and 6-MP, well established, there is an increased risk of certain types of malignancies. Lymphoma is the main one. That is probably threefold over the general population, the risk, well established in numerous registries. The malignancy that really folks got very excited about 15 years ago or so was the hepatosplenic T-cell lymphomas. Very rare, very bad malignancy. That one tended to occur in young male patients. What's young? Less than 35, but many of those patients were in their teens. And when the cases first began to be recognized, they appeared to be uniquely on a combination of an anti-TNF agent and a thiopurine. So after that, many pediatric practitioners abandoned the utilization of both those medications together, emerged with a new treatment pattern, primarily substituting the thiopurines with methotrexate, or using one drug all alone, like the anti-TNFs. That's fraught with still ongoing controversy as far as whether the single drug alone is going to be problematic as it relates to the body's own reaction against the drug and loss of durability. You can find data on either side to support that. So that's still an area of controversy, really. But you asked me about malignancy. So that's the definite. The thiopurines are associated with lymphoma, and that risk, again, is probably around threefold over the general population, established in many different cohorts. I think it's also important to note that that risk appears to be most closely tied to ongoing utilization of the drug. So having taken it 10 years ago is not such a concern. And probably half of those lymphomas had to do with a virus, the virus that causes mono, EBV. So some practitioners, as another safety net, would not like to start a patient on a combination therapy like that if they've never been exposed to EBV. So you see some people checking that in their patient population. Nearly all of us, by the time we get to adults, have been exposed. So that's a for sure. The anti-TNFs are interesting, okay? I think as data continues to emerge, the rheumatoid arthritis literature would suggest that certain types of skin cancers are at increased risk on an anti-TNF. If you look at the inflammatory bowel disease registries, these large cohorts and collections of patients that are exposed to the drug or not exposed to the drug, I think it's fairly reassuring. The largest pediatric look at this is called the Develop Registry. And in that registry, we couldn't find a clear link between malignancy and the anti-TNF alone. It seemed to be the risk was largely carried with thiopurine. That being said, I think there's still concern and controversy. And the skin cancer issue, I think, is probably true. As far as some of the other newer medications, we probably don't have enough data. I would say that the anti-trafficking medications, like the vedolizumab that I mentioned, there's been some large kind of surveillance type registries, real world experience that's been built since that medication's been approved and released all over the world. And I think that's quite reassuring as it relates to cancer. I never like to go as far as saying it doesn't, okay, but I think that the data that we have to date would suggest that one's not associated, okay? And the other therapy that's really making its way into prime time that has been available for many years now in the psoriasis field is the generic name is ustekinumab. And there's a large psoriatic database, okay, that's being gathered on that medication, and that medication also seems reassuring as far as an association with malignancy. I did want to back up and say one thing for people to know, because if they read the labels on these medications, they'll see something come out. The vedolizumab is a follow-on product from another trafficking agent that's older, so-called natalizumab. That's a medication that's approved to treat multiple sclerosis because it blocks how cells traffic to the CNS, the central nervous system. There were some associations between a very rare but very bad disease called PML of the brain. And we don't think that there's a concern with vedolizumab with that particular disease, but it still makes a black box warning. There's still a concern about that. So I wanted to make sure I touched on that.
So we have a few minutes left, Megan. I do want to go into more of the day-to-day IBD management that kids can expect and what they can work towards.
Yeah. Well, one of the big questions I get is, how is this going to affect my everyday life? How am I going to go to school? How am I going to play sports? Whatever you want to be involved with. And I always try to encourage patients to say, we want to help you, tailor your medical therapy or do everything we can to get you doing what you want to do, living the life you want to do. We want you to be going to school every day. We want you to be involved in all the sports you can be involved in or whatever it is that you're interested in. So part of that is working, especially with the pediatric population, working with their school, potentially to start a 504 plan. So what that is Crohn's and ulcerative colitis have been deemed a disability under the Americans with Disabilities Act. So working with your school to establish a 504 plan is basically putting in place those protections to say, yes, I have this diagnosis and these are the accommodations that I need in order for me to function in my daily life with this diagnosis. So accommodations are really different, and we tailor that, the school will work with you to tailor that 504 plan depending on what accommodations you need. Some people might need a hall pass to go to the bathroom. Some people might need to miss school, whether they're coming to meet with Dr. Faubion, they're getting a scope, or they're sick with a flare. So how to put those protections in place so that they're not penalized for missing school. Maybe, we don't want them to be held back from graduating, things like that. So that's what we always encourage people to do. The end of it is really, the big picture is just, protections for you to make sure that you can do what you want to do. So we always work with families just to make sure that they're aware of that, and then having them reach out as they want to, whether it's support groups or things like that, to engage with other people with a similar diagnosis. So that can be very important for kids, is to identify. There's a strong Crohn's and Colitis Foundation that has lots of information out there, that has support groups, things in the area, other people they can connect with. And we always kind of help people navigate that to help them see what's out there, what can they find online, how do they connect with other people going through a similar experience, to navigate that home life. Yeah.
All right, well, thank you for joining us today for a discussion about pediatric IBD. That's all we have time for. Dr. Faubion, Megan, thank you for joining us for such a great discussion. Any questions you have about pediatric IBD, we're happy to answer afterwards. This discussion will be available on Mayo Clinic's YouTube channel for future viewing. If we didn't get a chance to answer your question, we'll try to do so after the broadcast. Thank you and have a great day.